Good morning. I'm really happy to be here today, get to talk with you guys, and I think sessions are the most fun and helpful and educational when people kind of chime in. So we have 40 minutes of talking and then 20 minutes of kind of question and answer time. So, and I tend to do talks by telling stories. So objectives and stories are pretty much what you're about to get. So we're going to be talking about palliative care and what are we doing at KU to integrate seamlessly into the blood and marrow transplant program. And then explain like how do we do that compared to the conventional idea of what palliative care is, so we can break down the conventional idea and move forward to something that's more helpful for everybody. So you're going to learn about that. So we'll talk about the range of services that palliative care specialists provide. We're going to talk about the difference between hospice and palliative care, how palliative care specialists help transplant survivors manage health goals over time in an iterative process. And then also we'll talk a little bit about what are resources for finding a reputable palliative care specialist where you're at, or if there aren't integration of the programs, how you can champion that integration where you're at. So starting off, we'll talk about palliative care. What is it? What does this word actually mean? It's specialized medical care for people facing a serious illness. And so serious illness means something that's going to impact that patient and family in a global way, physically, emotionally, financially, spiritually, practically. When I start thinking about a serious illness, somebody's full-time job to survive the thing. And when I work with our transplant patients at KU, it's readily apparent to me that it's all in for the patient and their entire family. And when a medical process is putting you through that big of a change, and your family through that big of a change, sometimes you need, and all the time you need, people who know what they're doing to understand the issues and listen, and then make sure whatever we're doing medically fits and helps that person and their family going through it stay in the driver's seat as much as possible. As much as possible is big there. I know anyone who's been through a transplant knows you have to set aside a whole lot of control and hand it over to the people who are getting you through that process, and the trust that's needed there is so critically important. So palliative care is appropriate at any age and at any stage of illness, of serious illness. And when I think about when should palliative care be involved, it's really more about a measure of distress that person's going through at that time. And so my services can go in and out in terms of importance for a patient through the pre-transplant process. And we're talking about usually allogeneic transplant. And though we see plenty of folks who've had auto transplants too, through that time where the needs are higher, and then in times where the needs aren't as great, we're still there in that continuity relationship. We may be managing one symptom, or we may be just being a safety net of collaboration if that person's in and out of the hospital. So it can be provided along with curative treatment. This is probably, when we think about the misconceptions of what palliative care is, this is a big one. And in the medical culture globally, I'll tell you that when doctors and systems think about palliative care, it's easy to put everybody in a little box. And the palliative care box can be the stop box or the we don't have anything else box. Anybody heard? Yeah. So I'll tell you, when we first went down to the cancer center, there was this idea, and globally, this idea of there's the go team and the stop team. And we get palliative care when we need the stop team. And it's just really not a very helpful thing. So one of the first things that we did was to try to, and it's an ongoing process of saying, that's not how it works, and not how it should work if everybody's doing the very best possible. So I use my hands. It's hard to... I showed the oncologist what it feels like for them and for us and for the patient when we have a go and a stop team. So here's the oncologist, and the oncologist is holding the patient and the family, and they're going, right? And we're over here, and in a bad model that we need to move away from, the oncologist goes, it's time to stop. I'm going to get the palliative care team. And then they go, ooh, and they try and hand over to the palliative care team. And the patient's going, I don't want to be thrown, right? Please don't throw me. And the palliative care team is going, please don't throw the patient, because then we are trying to pick up a lot of pieces at a moment of real distress, you know? And the oncologist going, I don't want to throw you, right? So it's a model that works for nobody. So the new idea and the thought, and we went and I actually used my hands in department meetings where I said, here's you holding the patient, right? Here's palliative care, an extra layer of support underneath you. We're here all the time. Let's say we come to a day where we just have to think about things differently, or we come to a place where we need to shift a little bit. Here's what we do. Right? Everybody stays. Nobody gets thrown. Nobody has to throw. The patient and the family remain in the middle, held on by everybody. Right? And so that means a lot to me. I do that a lot. And it really shows, like, what should we be doing? And this is a winning proposition for everyone. So anyway, the other thing that comes up about that, like, when should we be thinking about this, is story my wife, and a wife of one of my patients when I was in training at San Diego Hospice. And so I did fellowship training in 2002 there. And we're in the inpatient hospice unit, and her husband is dying. And she said to me, what I just don't understand is why does somebody have to be dying to finally get this kind of care? You know? So when she said that, it really hit home to me. I'm like, we have a bigger job here. And that job is to not be stop and go. And that job is to not hold out on a really great set of services and support until somebody's in the last hours to days of their life. Because these concepts of really good pain and symptom management, of really good interprofessional communication, of making sure that a patient and family's priorities in their care are always in focus as we make medical care plans around it. That's just good medical care, right? That's just good whole person care. So I don't even mind if we don't say palliative care. Let's just do it. We can call it palliative care, but keep explaining, like, what is this that we're actually doing? So there's primary palliative care and specialty palliative care. So primary palliative care is what I'm talking about. You know, basic skill set in pain and symptom management, communication, advanced care planning, using a complex healthcare system provided by an interprofessional team of doctors, nurses, social workers, chaplains, PT, OT, nutrition, speech, the transport guy, everybody, you know. Going through serious illness and having to be in and out of a complex healthcare system, dealing with life and death issues for everybody is eventually 100% item, right? And so all medical providers need to be competent in owning that. And I believe that patients and families have a right to expect that we are competent. And so a big part of my job as a specialty palliative care provider is teaching primary providers how to feel knowledgeable and competent and confident in the care that they're providing. And it's really one of my favorite things is when I'm working with one of my partners who starts out kind of scared of how to do these things. And then I'm like, hey, we're going to go in this room and we're going to talk and you're going to talk. And if you stop talking, I will start talking I will not allow you to fail. You will not fail. You will do a good job, and we will come out of that room in a good place. And then they go in, and they're scared, and they start talking, and they get stuck, and I start talking, and they're like, I can do this. And then we do that 10 times, and then all of a sudden they're like, I can do it. And if I don't need to be there, I just taught someone to fish, right? Because there is a bottomless pit of need around these types of concepts. And so when I think of primary palliative care, that's what that is. Specialty palliative care is what we do have, a big team, and we integrate into our services around the cancer center and all over the hospital. But to say, how do we do that in concert with the primary providers? And it really is as an extra layer of support to the patient, the family, the team that's taking care of them. We do a lot of pain and symptom management and emotional support for the stress of illness. I have an oncology partner who explained it really well to one of my patients. We were in clinic, and he said to the patient and his wife, he said, look, I'm the pilot. I'm focused on all of the instruments and the numbers and making sure that everything is just right, aligned with the regimen in your labs and your scans, and I'm looking at all of the dashboard of instruments. And then he said, now Karin here, she is my co-pilot. She's listening for the hum of the engine. She's listening for all of the stuff that's in between that's impacting your quality of life and how you're getting through this experience that I may not catch in your labs, that I may not see in your radiology studies, or that I may not know about because I'm not in the room. So I like that one too, to really explain. And I think it's also important that my partners, when they say we can provide better care for you globally if we're together than if we're not. So how we think about putting all the pieces together there. So we help patients and families decipher medical information and help marry up that information with the patient's values and treatment priorities. And then that helps to provide really, truly comprehensive patient-centered care. I will watch, I'll be in a room in a conversation, and I'll watch my oncology or transplant partner delivering the information. And so my job then is to watch all of the recipients of the information for what may or may not be going through their minds. Like, did they hear that? Or what questions should be coming next? And so sometimes then I serve as an interpreter, turn it into English, or I'll think of a question like, okay, a lot of people, and I'll even say, so a lot of people when they hear that, they have this question. Do you have that question? And it's not unusual for someone in the room to go, yeah, they had that question, or they didn't understand, and they're like, oh, let's talk about it more. So to make sure communication's really, really effective. So the next slide is, it's a busy one, and I apologize, but it's supposed to be interactive, but it's not active. So I'll just talk about thinking about palliative care integrated upstream and what that can look like. And I'm going to start out by saying the old conception of what palliative care is right over here by hospice, right? The go-stop idea. And so if you think about the diagnosis of a serious illness, and this can be months, this can be a few years. When we think about this one, there's so much work, and benefit that we can help patients with from A over to F. And so you can kind of look, this is actually a tracking of a patient who was a solid tumor patient that we followed for about 2 years. And when the time came that that person was in a place where it was time for hospice, it was all done. There was no crisis terminal hospitalization. There was none of that because there was enough time to really think through and ponder and help that patient and family think about what was important to them. So I love, it's cool when the slide's empty and then you just get to see all of the little pieces stack up on top of one another. So more about what palliative care is. It's for people who are facing end of life. Palliative care can help to support and empower a person's shifting priorities, and can help support the transplant team and the patient family through that process, and then bridge to services. I tell patients when I start seeing them on the front end that we are their absolute champions for cure and for doing everything that we can to help get them through what they need to go through to live as well as they can, to tolerate the treatments as very best they can, and work with those curative goals as aggressively as we possibly can. And then I tell them, if there ever comes a day, it doesn't matter if it's 10 years from now, if there ever comes a day where the disease has changed and it's beyond everyone's control, I can stay with you as your hospice doctor. There's no reason why you need to ever lose me, because I do both. Do hospice and palliative medicine, right? And this is part of the reason why it's so confusing, because our field is called hospice and palliative medicine. And there are times where our behavior is very upstream and absolutely nothing to do with hospice. But it can be about hospice. And when I'm able to tell somebody that, like, I'm just going to stay with you and listen to you and advocate for you, and I'm a chameleon, and I will change what I'm doing based on what your priorities are for your care at that time in your life and in your living. And if there ever comes a day where those priorities are a comfort measure set of priorities, I'll be your comfort measure doctor, and I'll come to your house. So then it really brings it full circle. There. There's another story that I think is an appropriate one to share there, and that's that goals change and priorities change. Have you guys read the book When Breath Becomes Air? Have you heard of that one? Paul Kalanithi. I always say his name wrong. I think that's right. He was a neurosurgery resident at Stanford. It was either Stanford or UCSF. It was Stanford, yeah. And he had been through all of his training. He was getting ready to graduate. And you know how long it takes to become a neurosurgeon. So he's right on the precipice of getting to start his new life after training. And he was diagnosed with an advanced cancer that had brain metastases. And so he writes this book, When Breath Becomes Air, about how he worked through that process for himself, and also the interactions that he had with his healthcare providers and the communication that they had. And he said something there's a lot of take-home quotes. It's really good, but there was one that really stuck with me. He had 3 different sets of goals, depending on what the doctors were going to tell him, what his team was going to tell him his prognosis was. And he said, well, if my prognosis is that I'm doing well with my treatments and it looks like I've got years to live, then I want to operate. And so they're trying to decide what chemo do they give him, because there's some, that will cause bad peripheral neuropathy, and a neurosurgeon needs to have excellent use of their hands. And so what chemo do I get? Well, how long do I have? What do we expect out of this? And if it's years, pay attention to that, because I want to operate, right? And then he said, but if it's months to a year, then I want to write a book. But if I only have weeks to months to live, I want to be with my daughter. And so really different plans and hopes and priorities that he had. And what he needed there was for his professional team to be as honest as they could be, with the knowledge they had at that time about what he had to expect. And then he could marry up his priorities to that set of medical information. And the medical information changes over time. When we're talking about a serious illness, this is nobody in here's first rodeo, I would imagine, where you have one set of information and you make a plan around it, and then you get down the road, and now you have a new set of medical information, and you make a plan around that, and that is a process over time. And when I read that in that book, it hit home to me just exactly how important it is that we partner, the medical providers partner as honestly and using the best medical information we have at that time, to put together patient-centered plans that are driven by the goals and priorities for how that person wants to live. So I love this slide. There's kind of the politics of what is palliative care, and there's a camp who says, well, hospice and palliative care are different. We have to get palliative care away from hospice, right? And I'm like, well, yeah, sometimes, but sometimes not. Because all of my hospice patients, I probably have 5 home hospice patients right now, and all of those guys are on palliative care. They're all getting palliative care, right? It's just a focus of palliative care that's saying it's comfort measures now, and I don't want to use the hospital. I want a different part of the healthcare system to help meet my needs. But palliative care is the big thing, where over here, I'm helping somebody who has bad back pain before she's going to go into her allogeneic transplant. That's one of my other favorite stories. This young lady that we took care of who had a leukemia and was going to be getting an allogeneic transplant and had some bad pain. And then the suffering. I think part of it was also the suffering and the fear and anxiety about what she was going through at like 24, So we started seeing her then, got her through the transplant. She did well, and we were able to get her off of the pain medicines over time. And then enough time had gone by, I don't think she was breaking too many rules, but I'm at hot yoga. And she was there. I was like, I'm so happy to be seeing you at hot yoga and not at the cancer center. And so for her, we were able to be involved at a time of real stress and distress and be helpful and help her and her mom get through it. And then now I see her at yoga. That's over here. That's right there. And that it all makes sense. And that we can actually say the words hospice and palliative care together. We just have to understand that those circles the hospice circle is embedded within, and it's smaller. It's a subset of what we're doing. So palliative care is not about giving up. It is not in place of curative treatment, and it is not with a focus on dying. So it's actually about living. How do you want to live? And what am I doing to do my best job to take care of you as you live with a serious medical problem? And that really kind of flips it on its head. There's things we talk about with advanced care planning and what would you want to see happen if the bottom were really dropping out. And those conversations are really important to know because the nature of illness is that things can change really suddenly, And if we haven't talked about it ahead of time to know what somebody's values and priorities are, if they get really sick really fast and they're not in a place where they can convey what they think, we've lost our opportunity to empower that person to say what's important to them. So we talk about it ahead of time. But what's kind of hard about that one is that nobody wants to talk about it until it's just the right time, right? You don't want to talk about it too early, and you don't want to talk about it too late. You have to talk about it right at the right moment. And doctors are afraid to talk about it and don't have a lot of skill set sometimes. But a big part of my job is helping people be like, come on, we can do this. We can talk about this. It's all right. But there's a confluence of a number of factors that create silence of collusion and not talking about these things because it's scary and it takes a lot of time. But if we flip it on its head and just say, you know what, there is a moment when 100% of people die, but all the rest of the time, all the millions of us for all of our lives are living. And so we need to talk about how we live, and then how we talk about that with the people that we love, so that they know how we feel about things. So let's see. When we think about the benefits of palliative care, so this is from a lot of studies looking at what happens when you integrate principles of palliative care into medical practice and when you kind of utilize these services. So improved outcomes of quality of life, improved symptom management, better mood, less depression for both patients and caregivers, improvement in illness understanding, and we call it prognostic awareness, having a sense of that. Coping with illness, caregiver quality of life, satisfaction with care, and then when we talked about ahead of time, when folks come to the last days or weeks of life, they tend to, and they're really well informed and have had a chance to think about it, they tend to use healthcare systems in a different way at that time. They tend to want to say, if it's ever finally that time, I don't want to be in an ICU on machines. I'd rather have, a focus with my comfort in mind at home, if that's possible, et cetera, et cetera, et cetera. This is what's really kind of funny and ironic, that there's some studies coming out showing that palliative care improves survival. Go figure. It was a secondary endpoint of a study, and it was in lung cancer. But they compared folks getting regular treatment to folks who had palliative care right alongside them, and the folks who had palliative care lived 2 months longer. That's as good as Nevo. Have you guys seen the commercials for Optivo? Where that's as good as Optivo. So that's an important little piece too. We always think about the concept of palliative care means things are good, you're going to die faster. You're making a choice to give up something when it's not. It's really about adding extra support in, and that can end up helping people live longer. Sometimes because you can hit a moment where giving more treatment adds a burden on the body can't handle, and then it's harder. But anyway, I always think that's kind of funny. So palliative care can also help manage care goals. In our work with the bone marrow transplant population at KU, we work a lot with folks who have chronic graft versus host disease and the symptoms that go along with that. Physical fatigue, where there's another session that's going on in a little bit on physical therapy that from one of our guys up at KU. We manage I'm going to call it the marathon of coping. This is not a sprint, it's an ultra marathon when you're going through the transplant process and the survival from the transplant process. And we hear a lot about, a new pain. What is that? And this fear of, is that the illness returning? And how do I cope with that? Knowing, not knowing, emotional fatigue of those worries and the impacts of the chronic physical symptoms, the chronic financial burdens, and then the family stress of chronic illness. I've recently heard somebody tell me every single family is messed up. There is not one single family that is not messed up in some way. Even the normal families, they're messed up. Everybody is just on a continuum of how messed up we are. And when everything's going fine, you can keep all that kind of over in the corner and it's all compensated, right? But in moments of stress and trial, the dysfunction. And we're all messed up, but that's when it comes out, right? And when you're dealing with that in a chronic sort of way, that gives a lot of opportunity for the family dynamics to be chronically stressed. And so thinking about how do we work through that? How do we minimize that, or how do we help families have the tools to be as healthy as they can in their relationships? And that ends up impacting the person who's going through the survivorship process. So we talk a lot about understanding what to expect from illness over time, and then how to consider priorities for care over time. We've already spent a little bit of time talking about that. So a good palliative care team, what's a good palliative care team going to do? What I tend to like to do is just at first listen. Like, just go in and say, I just want to get to know who you are as a human being. What do you value? What do you worry about? What is most important to you right now? What is most important to you down the line? Who is most important to you? And what worries are, what unanswered questions are. Sometimes people, they've heard it, but they need to hear it from a different person. I like to identify who do they trust the most. I'm usually walking into a room as a stranger. Sometimes I have to share news that's not fun, and I shouldn't. Well, I need to be involved in that, but mostly I'm like, who do you need to hear this information from? And then I need to insert that person into this conversation so that you have what you need. So thinking a little bit about how to find a palliative care specialist. So this one's kind of tough. When we think about palliative care integrated into healthcare systems and where the programs are at, big hospitals, almost all bigger hospitals have palliative care services in the hospital. More and more palliative care services are integrated into the outpatient setting. There are fewer palliative care programs who are integrated into the blood and marrow transplant programs. Our program started in 2012, which I think was one of the first ones in the United States. I thought it was kind of fun when MD Anderson called KU to ask us what we were doing with the palliative care clinic in BMT, and I'm like, okay, we've arrived. I thought that was pretty cool. But so where you're at, you have to kind of know what are the local resources for palliative care where you're at. Is there already a program that exists? Is there an inpatient consultation program or an outpatient program that could be ready to build a relationship and integrate with bone marrow transplant? So this is a great resource on this slide, and I'm sorry it's kind of stuck up there. It's called getpalliativecare.org. There are several questions, resources there to help you know from a patient or caregiver perspective how to know, is it time for palliative care? And you've heard a pretty broad definition from me about how we work with palliative care. In your own system, they will have adapted that to what their workforce is. There are some systems who have a palliative care team, but they have like one doctor and a nurse and a part-time chaplain. And so they're trying to meet the needs, and there's a lot of needs. And so they may use a constricted or expanded definition of how they provide services based on their resources. I don't know if that makes any sense. We've been building we're incredibly well supported at KU. I'm so thankful that our administration understands these concepts. We see about 2,000 inpatient consults a year. We see about 1,500 outpatient encounters a year. Between medical oncology, heart failure, and the bone marrow transplant program. But we've got like 20 people on our team, to meet all of those needs. And so it gives us a little bit more freedom, to say, all right, we want to do this right. We want to provide the most intense and full service kind of palliative care that we can. And not every program is there. I know they all want to, but they may be limited by their resources at hand. And so this is a good place, though, to go and learn. And then you may have an opportunity to learn if that system is in a place where it could expand. You can say, hey, we need this. Systems listen to patients. Good systems listen to patients and caregivers and say, this is what I need, what I want, and taking that into account. So in 2012, Amy, my nurse, who's now my nurse, she was a bone marrow transplant nurse under the head of our program, and she cold called me. I'd never talked to this lady before, and she goes, Dr. Porter-Williamson, you need to come down here. I have patients that you need to see, and I have one for you tomorrow morning at 9. Can you come? And I said, sure. I had no idea that because I hadn't done clinic before. Just walked down there and figured out all the stuff I didn't know about how to do outpatient encounters. But I'm like, wow, this is a real opportunity. And that's kind of where it started. So it was one person saying, we need this, come. And then we built that mission and the program around that with support from the leaders of our program there. So this is just a little bit about how in your local area you may find that there's not tight integration yet. Or the transplant team might have an old definition in their head. Might think it's the stop-go deal. And then you can do the hand thing. So they might not know it can be in parallel with curative care or the quality of life benefits that can be conferred. So in summary, palliative care's specialized symptom management, communication, and coping support for those facing the stress of serious illness can be integrated as an extra layer of support with transplant care, helpful at any age and any stage. Is associated with multiple quality of life benefits for both patients and their caregivers. So now we have this part. We're going to turn to question and answer and more story time. And I invite you guys to kind of review your notes a little bit if questions came up while I was talking.
I just have a quick question because I have gone to several people and talked about cancer support. The support program network thing. What term am I trying to use? The first session we talked about your cancer support team. And then now we have palliative care. So when I approached some people at the UW, they said there's not a paid position for this, or their insurance is not covering these types of support. So how does everybody get paid to be able to do this?
Mm-hmm. So there's a couple different ways. One, when we think about palliative care doctors or advanced practice providers, I am paid the exact same way the kidney doctor gets paid. If, the transplant doctor consults renal, they come in and they provide a consultative service and they bill exactly the normal way for it. And so for myself, how I get paid and how advanced practice nurses who work with me get paid, there's a reason for consultation, which is usually pain or other symptom management. It could be expertise in counseling and coordination of care around that, around goals of care. Those are the two big ones, reasons why the primary would consult us. And we turn in the bills, and I'm very successful RVU producer. And it works out okay. When it comes to other elements of the team, in the outpatient setting, social work, LCSW, who's doing counseling, they can bill for their services. Our palliative care nurses, those are RN, nurse navigators. We have 3 in the cancer center, and they are paid for by the cancer center, and because they don't bill. And so they are an overhead expense for the cancer center, and the cancer center is committed to providing that team for us. When you look at the finances of palliative care, there's the billing element of it, but there is strong evidence that high-quality palliative care improves the value of medical care, and the definition of value is quality divided by cost. And there is a cost element here. When we do everything that I just talked about, quality goes up, costs go down. And systems can see that, and then they can understand okay, I can invest in you because you, palliative care team, will improve the value of the services we are delivering to our patients and families, and that's what we want to do as a system. So it requires the system to understand the value equation.
I don't find it where I'm at.
Yeah. I think that, I think there's a lot of work to be done, and there is a lot of advocacy from the professional side of advocacy, and then also the patient, family, public side of advocacy. And I think I'm probably, because you guys decided to come to this talk, I'm probably preaching to the choir here a little bit about the value of what palliative care does. But we're a pretty small group in here today, I'd say that that when it comes to these concepts, there's a lot of culture shift. There's a lot of grassroots, what is this? To help people really understand, so that it's not everything we just talked about, so that it's not scary. And this is about quality of life and living, and not quality of life in the face of dying, quality of life in the face of living with a serious illness. And I think there's still many institutional barriers and kind of public conception barriers to break down. Now, what's funny is they did some public surveying, of terminology, and they asked folks, so random members of the public, what a definition of palliative care. And when somebody had no conception of what palliative care was and they heard about it, was like 90% positive. They resonated with what palliative care was, and it wasn't scary and it wasn't negative one single bit. It becomes negative when a doctor comes in the room and says, there's nothing else we can do, we're going to get palliative care. And so, well, no, so that's where, and it's a shift that needs to happen. And so I'm pounding on the doctors' heads all the time. Stop saying that. That's not true. But there's a long way to go. And you got, I'm putting you on my team. Yeah. Go shout it out. Yes, sir.
Okay, thank you. I don't have a lot of knowledge about this, but what you just said about it resonating and it's positive when people hear about what it is, that's what I'm just experiencing during this talk. So I appreciate that. So the question is kind of a follow-up on this, how to access this. I have multiple myeloma, so it's this years-long thing of a drug working and then not working and then going through the anxiety of, okay, what are we going to do now? How are we going to treat this now? And ultimately running out of options, which is kind of where I am at that end of things. And so it's, again, kind of a question of how to access this and not even knowing my pain. So my pain is managed. Some of the other symptoms, side effects, they're all being managed through my oncologist. But some of the other things you talked about, sort of the anxiety of coping with the emotional stress of dealing with this disease year after year after year. So I don't even know quite what to ask my doctor for.
Yeah.
But it feels like it fits under what you're describing. And so
if you go to your oncologist and you say, here's all of the things that I'm experiencing, and you talk about, that everything's okay and you got a plan, and then something changes, and then it's like, you kind of starting over, readjusting, making a new plan. And so if you're able to say to your oncologist that is there extra support from the cancer center around coping with that and around thinking through these decisions and, extra support. So cancer centers have some should have some NCI designated places. Are you at an NCI? Do you know?
I'm sure I am.
Yeah.
I'm at City of Hope.
Yes. Well, there's palliative care at City of Hope. And they also, so there are oncopsychology services. These are psychologists who specialize in cancer and coping with cancer, the emotional ramifications of that. And so in my little BMT pod, there's me, and I sit next to the psycho-oncologist, Megan Dwyer, and the BMT guys through the glass can see him. I got a social worker next to me. I got my nurse. So, and they're fairly integrated teams, and City of Hope should have psychology, social work support, and palliative care. I would say, I learned about this, and say, what do we have here, and how do I access some of that to explore my thoughts? And your doctor will do one of two things. He'll go, oh, awesome. Oh, why didn't I think about that? Oh, of course. And, or he'll go, oh no, we can still do the clinical trial of the blah, 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 blah. And because he may have a stop-go conception, he or she may have a stop-go conception, and you say, it's all right. I heard you can do clinical trials and see a palliative care doctor at the same time. Nothing bad happens, like this guy doesn't fall. So that would be my thought. Anyone else have a thought?
Well, I'm sorry, just one. So it is a referral from my doctor, though. That's the mechanism to make that happen.
Yes.
Right? Okay.
Yeah. A referral from your doctor, and depending on the kind of services. So full-blown, I want to see the palliative care team should probably be a formal referral. And psycho-oncology would also probably be a formal referral. And the reason why is that we have to prove, if anyone's going to get paid for it, we have to jump through all the hoops of providing the service. They may have other things integrated in their social work or care coordination department that aren't billable and are accessed through your main team. So you can ask about both of those.
Okay.
I have a question. From a small town 2 hours away from a transplant center, I've been dealing with this stuff by myself, and my own caregiver, even through transplant, the whole time, drove myself to treatments, drove myself to pheresis, drove myself everywhere throughout the whole thing. Never had anyone 100%. I lived at a transplant center, St. Louis area, for 2 years because I had to drive myself back and forth to my things. How would this work? Like, I know they're talking about a palliative care in my area. How do they communicate back and forth between the main transplant center and that? Because I am tired, I'm worn out. I went through aggressive PVET, MF, MDS, had the AML mutation ever since 2002. I'm tired, I'm worn out, I need help.
Yeah. Oh, you're a tough lady. That's a long time to be going through this. Yeah. So my first suggestion, kind of a little bit along the same lines, that we talked about is asking them what we know. There's palliative care coming down the line, but how does that work? And then what are the kind of, for your travel, how often are you having to go right now?
Right now, I actually went back to living back home right now. I still go once a month because I have to get some special contaminating treatments, everything else.
Yeah.
And, mine is really rare. Myelofibrosis is completely rare. People aren't familiar even with transplant that much in my area. No one understands it. Way above their head.
Yeah.
I'm from Effingham, Illinois. It's a small little area.
Yeah. Yeah. So I won't have awesome answers. But having kind of lines of communication with the transplant center, making sure that any resources they can add in where they're at in St. Louis, and then coordinating the timing of those appointments so you don't have extra trips. Our nurses spend a lot of time embedding, our appointments when they are at the cancer center for another reason so they don't have another day, of travel. The other thing that I wonder about, and it's hard because it's not anywhere close to where I work, but what we're working on developing telemedicine services, and thinking about do we need an in-person visit, or can this be a phone visit instead? Now in these kind of circumstances they're going to want to see labs and et cetera, et cetera. But the other thing that you can talk with them about, if they're saying, here's what you're living with now, what else can we add in, not add in? You can say, I'm tired. I'm tired. I have a different set of priorities, and here's what I'm thinking. How do we put together a plan that fits with my priorities, and then kind of negotiate that with them. if they have palliative care that they can bring in, that palliative care doctor will listen to that and work with the transplant providers, about that. And it gets to be kind of a rank order,
I'm at that point right now because my transplant doctor is trying to dismiss me. My local oncologist doesn't want to see me because he doesn't want to step on my transplant doctor's toes. I'm getting treatment. I'm just using my chair time in my local area. And I need help because I don't know who to ask what questions. They're all pushing me off somewhere else.
Yeah. Is there a social worker locally or with the transplant center?
I just have the one that's in St. Louis.
Yeah. Yeah. I think I would go to that person and say, here's all the things that I'm thinking. That person, that part of the transplant team's ears may be open in a different way that will listen and carry that information back, So I hope I'm being helpful, but it sounds like.
Thank you.
Yeah.
So, I've been doing all of this for 13 years, and I'll give you a hug, and if you want to exchange emails, that would be wonderful. In my head, I have shifted from seeing myself as a patient to a person who is a client. And sometimes I have to use my voice and not feel like I'm weaker or lesser than the community of doctors. I have to say, this is what I want. And if someone says no or dismisses me, I'm not going to feel guilty or shameful or I'm not worthy. I'm going to stand up and I'm going to say, wait a second. You need to listen to what I'm talking about and negotiate, talk, whatever, you have to do to make yourself heard because you're worth it. Nobody gets to dismiss you, Sorry.
No, that was good. I'm glad you said it. Yeah. Are there other questions or comments or thoughts?
It's more of a comment. Do you think resistance to palliative care is due to the strength of hospice? So the hospice movement has been so impacting across the country that the general public associate with hospice, but it's hard for them to transition to the thought of palliative care. Could there be that connection?
I think that's a really good point. I think a lot of people understand what hospice is, and the trouble, it's good and it's bad. There's this self-fulfilling prophecy of you full bore ahead, it's the stop-go thing again, and the hospice side of that equation. And so I always tell people, because people have a conception of hospice as absolutely the wonderful set of services you want when you're at end of life. And that means actively dying, and that's hours to days. When hospice can do its best work, when they have days, weeks, months. And so hospice, there's this good idea of hospice, but it's only for the very, 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 very end. And then if you tie anything to that, that pulls it into the very, very, very end. And I think that's part of where it becomes hard. And what we need to break. My favorite hospice story is, the other thing that is important to say here is that blood cancers operate in a different trajectory of illness than solid tumors. And so the nature of leukemia and recurrent leukemia, recalcitrant leukemia is that you're plowing full bore ahead and you're in remission, and then bam, something changes on a dime, and then the transplant team comes in and goes, oh, it's all different. 5 days ago everything was fine, but now I'm telling you, you only have weeks to live. And so the trajectory of blood cancers is sudden. It's more like a traumatic illness, GVHD, that progresses in more of a non-cancer sort of stutter step, nasty, roller coaster ride. of a long time. So how we use hospice services in bone marrow transplant patients is different than how we use hospice services in ALS or, but the trick there is really good understanding of it, really good outlining of what those goals and priorities are, so that if anybody ever flips the switch, we're on. We're ready to go. It's all lined up, and then we've even in bone marrow transplant, we've been able to flip that switch, get hospice out to the house without a big hospitalization but it means upstream work. Thank you.